Honored to introduce Professor Ranjan Gupta. He is working in the Department of Rheumatology, AIMS, New Delhi, and he is the Indian ambassador for APLAR Young Rheumatologist. He is also associate member of Autoantibody Standardization Committee of IUIS, and he is executive committee member of Indian Rheumatology Association for the year 2023 to 25. His areas of interest are SLE, lupus nephritis, and biomarker-related research in ANA immunofluorescence patterns, and most important, patient education. He has more than 45 publications to his credit, and he has authored 4 books and chapters. And the other notable achievements of Dr. Gupta is he is APLA Center of Excellence Exchange Fellowship he received in 2022, and Young Rheumatologist Oration by IRA in 2021, and Shakuntala Amirchand Prize by ICMR in 2018, and the Best Original Paper Award in Basic Sciences Eracon in 2013, and also Vittal Rao Nagathur West Annual Thesis Award by API in 2012. I welcome Dr. Ranjan Gupta. Over to you.
Thank you, ma'am, for this introduction. Speaking about interpretation of immunological tests. So since I'm a clinician, my talk is going to revolve around clinical problems and how we put these tests into perspective while interpreting and while applying them in the clinics. And I would also like to share a few things about how and what we should be expecting from pathologists and biochemists who are out there giving out these results. So what as clinicians we expect from them. So I usually give this example when we talk about autoimmune diagnostics. It's a simple sentence which says, I hit him in the right eye. And I'll try to put a word only in this at different positions, and you see how the meaning changes. So if I put it in the leftmost position, it says only I hit him in the right eye. I move it one step towards right and says I only hit him in the right eye. It says I hit only him in the right eye. I hit him only in the right eye. I hit him in the only right eye, and I hit him in the right eye only. So you see just one word, how it has changed the meaning completely. And the same is true when we come to autoimmune diagnostics. As highlighted by Dr. Ajay Gupta, these tests have different specificities and sensitivities, and that's why their interpretation is likely to be, they are likely to be misinterpreted if not put into the right clinical context. So these are the common tests. We all know that we do these tests for different conditions. But the problem comes when these tests are either not they are not the way as we expect. So if in lupus ANA comes speckled rheumatoid arthritis antibodies are negative, and similarly in other diseases, if these tests are positive or negative unexpectedly, what are we supposed to do? So that's what I will be talking about over the next 20 minutes. So I have some cases and some lessons for clinicians as well as for pathologists and biochemists. And I'll be mainly touching upon rheumatoid factor anti-CCP, ANA, ANCA, and APS-related autoantibodies. So my first case is about a 56-year-old obese man. He complains of 2 years duration of bilateral knee joint pain, but he has no swelling. This pain is mechanical in nature. There is no early morning stiffness. History of joint crepitus is present at the knees. On examination, I don't find any swelling, but there is joint line tenderness. What test would I like to order? This patient has got this kind of x-rays, which shows me that he has got middle compartment joint space reduction. Would I like to order a test here? Do I need a confirmatory test? It's a 56-year-old, that too man. And as I just told, it is more commonly present. ANAs and other things are more commonly present in female, and their positivity increases with age. So my diagnosis here is osteoarthritis, as is clear from the history. Similarly, another patient who comes with this similar x-ray, everything, and an enthusiast in turn sends an ANA which turns out to be positive, a rheumatoid factor which turns out to be positive. I'll just try to hide this panel. Actually, it's hindering my view. So let me just. So anyway, let's go. So even if these tests come positive, my diagnosis doesn't change. So ANA, if it is positive, again, my diagnosis is osteoarthritis. Why would I like to send ANA? And the diagnosis still remains the same. Similarly, now I have a 56-year-old obese lady. So means we are talking about that these antibodies are more commonly present in ladies. So I have a lady who is now having a painful swollen knee for last 2 months. There is no fever. On examination, she has got a swollen and tender right knee, which is warm on touch. What is my likely diagnosis? Here, I'm not thinking in terms of septic arthritis because the duration is 2 months. The X-rays are almost the same as we saw in the earlier case. Even if ANAs are positive or negative, or ESR is slightly high, or CRP is positive, still my diagnosis will not change. I'm only thinking that she probably has osteoarthritis, which is in its inflammatory phase. So it is basically an inflammatory OA where I don't need all these tests to be done. Another lady, 50-year-old, 5 years duration, bony swellings at the fingers, which are bilaterally symmetrical. She has got no swelling, no early morning stiffness. On examination, some mild tenderness is there, otherwise there's nothing, and these are bony hard nodules. You can see these. These are typically known as Bouchard and Heberden's node, as we see in osteoarthritis, and you can see there also there are suggestive changes. So in such a patient, I would not like to order any tests. Even if these tests are ordered and they turn out to be positive, my diagnosis still remains osteoarthritis. Another lady, similar complaints, 10 years duration. This patient came to my OPD with all these actual reports of ANA, RF being positive. And you see the positivity, it is low intensity positive speckled pattern, which is the commonest pattern across the diseases, even in healthy individuals. And I see that these are the bony hard nodules that lady has been talking about. She has got no deformity, nothing. And on X-ray, I see this typical first CMC involvement, which is for osteoarthritis, and my diagnosis would be osteoarthritis and nothing else. So antibody stands for immunity, but autoantibody do not stand for autoimmunity. Autoantibodies are relevant for deciding a case for autoimmunity only when it is in particular clinical context. Prevalence, their prevalence increases with age, mostly in ladies. They are false positive when people have viral infections or cancers, and as we go higher the dilution, their false positivity decreases. As we go lower the dilution, their positivity rates would be higher. And that is why a particular dilution should be fixed by every lab where they test at what dilution they test these antibodies. And they are the usual suspects, but mostly they are innocent and they don't do anything. So clinical impression should be the best guide when we are talking about autoantibodies. Similarly, rheumatoid factor positivity is not equivalent to rheumatoid arthritis. It is a type of IgM anti-IgG antibody, and you see various diseases where rheumatoid factor can be positive. Again, its positivity decreases when you test it at higher concentration. When you increase your cutoff, the false positivity or the irrelevant positivity goes down. So a young lady who comes to somebody with complaints of epigastric pain, undergoing a health checkup, and has an autoimmune panel which is showing RF positivity, actually nothing is required to be done unless until patient has got suggestive symptoms. So asymptomatic positivity does not require any treatment. If we look at the same thing is highlighted in this 2010 rheumatoid arthritis classification criteria, you see this criteria is to be applied to a patient who has got at least one joint which is definitely swollen. Synovitis includes swelling and tenderness. It cannot be that we tried applying these criteria. Whoever is positive for RF or anti-CCP in anybody who comes to your OPD and has a rheumatoid factor or anti-CCP positivity, we cannot keep applying these criteria. At least an entry criteria of having one swollen joint has to be satisfied. And again, they are very particular in telling that this one swollen joint cannot be DIP joint, first MTP, and first CMC. First CMC, as I just showed you, it is typical for osteoarthritis. First MTP is common for osteoarthritis and gout, and DIPs are more common for osteoarthritis. And that is why these diseases, which are more common than rheumatoid arthritis, have to be excluded. Then you can go on applying these criteria and trying to classify a patient to be having rheumatoid arthritis. Next, we come to 30-year-old lady, 12 months duration, early morning stiffness of 60 minutes who has pain and swelling of bilateral small joints of the hands. DIPs are spared here. So that means I am unlikely to be encountering a lady with osteoarthritis. Again, age itself tells me that osteoarthritis is less likely. She has got swollen tender joints of MCPs and PIPs. So what is my likely diagnosis? This is the hand picture. As I can see that MCPs and PIPs are swollen. My likely diagnosis would be X-ray showing a similar juxtaarticular osteopenia. Even if she is rheumatoid factor and anti-CCP negative, my diagnosis would be rheumatoid arthritis, which is seronegative. Similar complaint, similar lady, another lady who has got similar complaint, similar hand picture and X-ray. This time, if my rheumatoid factor and or anti-CCP is positive, I would classify this patient to be rheumatoid arthritis seropositive. So my diagnosis was rheumatoid arthritis based on the clinical picture. Seropositivity, seronegativity just lets me decide what the variety of rheumatoid arthritis the patient is having. Another lady, similar duration. Now DIPs are involved. There are some nail changes. Fusiform swellings are available there in the fingers. You see these nail changes. So my likely diagnosis here, even if the clinical picture is same, but DIPs are involved and similar things, some different things are there, I would classify this patient to be of psoriatic arthritis, even if his or her rheumatoid arthritis, rheumatoid factor and NTCCP is positive or negative. I come to a 20-year-old male with symptom duration of 4 years who has got low backache, which is inflammatory. There is a family history. He has got bamboo spine, history of uveitis is there, restricted spine mobility. I mean, everything is there that tells me that this patient has probably got spondyloarthropathy. I see his X-ray, which is showing me this sacroiliitis on both sides. My diagnosis would be ankylosing spondylitis. It would not matter if the patient has got rheumatoid factor positive or negative. So things go with clinical impression. What we are thinking, as somebody had asked in the previous session, what do we do if ANA is positive and the lady is pregnant? We don't do anything. We simply pacify them, reassure them that it does not require any treatment unless until you got symptoms, related symptoms. Even in this patient, if ANA is positive, we need not do anything. Now I got a 20-year-old male, 2 days duration, sudden onset pain and swelling of the knee. So it's sudden onset pain and swelling of the knees. Preceding diarrhea was there 2 weeks back. There is a past history of similar complaints in one knee and ankle 3 years back. So there is a past history. He has got preceding diarrhea, which was 2 weeks back. On history, it looks like that patient has got probably reactive arthritis, and I have got this swollen knee, which is there. Even if my antibodies are positive, I am still going to make the diagnosis of reactive arthritis, irrespective of what these antibodies are. Now I have similar lady that we had a few slides back, 30-year-old lady, 12 months duration, bilateral symmetrical involvement, early morning stiffness is there, and DIPs were spared. We classified this patient last time to be having rheumatoid arthritis. X-rays are suggestive. So this patient, I had no doubts. I would say probably this patient has got rheumatoid factor positivity. Luckily, this comes positive. I would say that this patient is probably having rheumatoid arthritis. But people who are clinicians may like to ask a few things, because at this age, we also consider a possibility of lupus, which can present the similar way. So we asked everything. Patient did not have any suggestive history of malar rash or anything. And his hemoglobin was 9.5, TLC was normal, platelets were 1,100,000. So I thought probably patient is doing fine. I started the patient on methotrexate and asked to come back after 2 months. But patient returns to me a month later with this. So did I miss anything in my first observation? When I saw the patient, did I miss anything in the history or anything, history or examination? Actually not. But if you go a bit deeper, you see that this patient at the beginning itself was giving you some signs that she was having more than rheumatoid. She was having mild anemia. There was lymphopenia, and there was platelets which were borderline norm. So it tells me that this patient could be having something more than rheumatoid arthritis, because in rheumatoid arthritis, usually we expect thrombocytosis rather than thrombocytopenia. So should I ordered ANA, or should I order ANA for all such patients who come with symmetrical arthritis? So the answer is again no. Unless until you get some signs or symptoms, you should not order ANA for all patients, because even in rheumatoid arthritis, almost 40% is positive for ANA itself. So if you start ordering for everybody, you are going to get at least 40% patients back with ANA being positive, and then you will be forced to order further battery of tests to actually exclude rheumatoid arthritis, which is a possibility of in almost 90 to 95% patients who you see in the OPD. And similarly, these are other classification criteria, basically for lupus, where you have other antibodies tests or complements or dsDNA and other antibodies. Now, this lady wanted a pregnancy. She was counseled for pregnancy. And a year later, when she has a baby, she has this rash, which is typically known as neonatal lupus. So this is the case of neonatal lupus. But then once we are counseling for pregnancy, we should always try to rule out possible other things that can happen in such a case. So this lady is lupus. I know that lady with lupus can have neonatal lupus. She can have APLA. So at that time, before advising for pregnancy, I would actually like to do a further some more tests. That is the time when you should order these tests and try to, before reassuring the patient, you should give them the clear picture that that is what is expected and that is what you could have during your pregnancy. If the patient, the child doesn't have neonatal lupus, this is another complication. This is congenital heart block can happen in 2% of patients who have anti-Ro or anti-La antibody positivity. But if the first pregnancy is affected, the chances increase to 8 times. It becomes 16% after the first affected child. I'll come to some more cases. A patient with tuberculous lymphadenitis on ATT for 2 months and apparently responding. New onset fever. Patient develops, who was responding to ATT for TB lymphadenitis, develops new onset fever, malaise, and myalgia. There is no cough, there is cough but no expectoration, and his chest X-ray is showing me a new pleural effusion. So, what is the likely diagnosis? Am I dealing with the resistant TB or is it something else? So, when a patient is on ATT who seems to be apparently responding, develops new features, we should always remember that there is an entity called drug-induced lupus where ANA can be homogeneously positive and ENA can show anti-histone antibodies. So, this will all depend on how good we take the history, and then we decide on what tests would we order. If we don't think of this entity, any clinician would go on thinking that this is a resistant TB, will go on ordering, tapping this fluid, getting the cultures, increasing the antibiotics, and then in turn increasing the resistance in the bacteria. There are certain criteria, but the main thing that you must remember that the antihistone antibody is positive in almost 100% of patients. ANA is positive in 100% of patients. And then you hardly ever develop lupus nephritis. So lupus nephritis is usually not a feature of drug-induced lupus. So we need to remember these cases highlight what is the positive predictive value of ANA. ANA is 100% sensitive for lupus, very sensitive for Sjogren syndrome. But we need to remember that out of 100 patients who test positive for ANA and come to my OPD, I'm going to get one of these diagnoses of lupus or Sjogren in only 10 to 25% cases. Across the series, you do by whatever test you want, whatever method you want, your actual yield in terms of getting a disease behind the ANA is going to be only 25% patients. So order your test judiciously. Unless until we know when to order, these tests are only going to hold our OPDs with false positive results. So to make to basically decipher what it is going to come out, I usually give these mnemonics of SNOUT and SPIN. So SNOUT stands for sensitive tests. When negative, rules out the disease. Specific test, when positive, rules in the disease. I'll just give you two examples. So I have a 23-year-old male, inflammatory low backache, bamboo spine, uveitis, family history of ankylosing spondylitis in 3 uncles. Would I like to order an ANA to rule out lupus? My pre-test positivity itself is so low. This patient already has a diagnosis written on his face of ankylosing spondylitis. I would not like to order an ANA. Even if it comes positive, I know that it is highly sensitive. It will be positive in all lupus, but then it can be positive in all myriad of diseases. So I would simply discard even if it comes positive. Similarly, I got another young lady, malar rash, oral ulcers, alopecia, renal biopsy is done, which is suggestive of MPGN. Would I like to order an anti-Smith antibody just to complete my workup? Because I know this lady has got lupus, anti-Smith antibody, even if it comes negative, is it going to exclude my possibility of lupus in this patient? We need to remember that anti-Smith antibodies is a highly specific test and has got low sensitivity. It will not be positive in all the patients. It will be positive only in a set of patients. So highly sensitive tests applied to a non-specific population rule out the disease. Highly specific tests applied to a very specific population to rule in the disease when the diagnosis is in doubt. And we should never confuse it with HIV ELISA. Actually, this is for clinicians. I know all the pathologists and biochemists would be knowing this, but an HIV ELISA is usually highly sensitive and highly specific. Unlike ANA, which is highly specific, highly sensitive but non-specific, or unlike other antibody tests like anti-dsDNA, which are highly specific and non-sensitive. So usually we have been taught during our graduation and post-graduation that once you have an HIV test positive, it is almost certain. Yes, that is true. But then because this test is so good, it is highly sensitive as well as highly specific, which is not the case with autoimmune diagnostics. So ANA has got different antibodies which have association with different types of manifestations. I will not go into the details of it. But what I would like to say here, the role for pathologists in reporting antinuclear antibodies would be to at least tell the dilution, the pattern, and the intensity. At least these three things have to be there when a report goes out from your lab. As Dr. Ajay Gupta had highlighted that we have got almost 28, 29 patterns now, and they are divided into competent and expert level. Even if expert level patterns are not reported, at least competent level patterns have to be reported. There is no use of doing end dilutions. Nowadays, that has got less relevance. Dr. Ajay Gupta also showed you that in ANA classification criteria, now it has been made mandatory to have ANA tested at least at 1:80 or more dilution. Usually, these more dilutions are not required unless you are highly suspecting lupus in a patient where tests are negative. Only in those patients you should ask for a higher dilution. Otherwise, higher dilutions are not required. In Indian population across the studies, 1:80 to 1:100 is considered to be very good. And all reports must report, all laboratories must report at least the competent level. Intensity, if you give us, it generates more confidence into your report. Like I'll show you this lady who came to our OPD a few days back. So she has got inflammatory arthritis. Somebody was treating with sulfasalazine, and she used to complain of these rashes whenever she used to take sulfasalazine. So probably it was just coinciding with her sun exposure. You see these rashes coming in the sun exposure areas. So we thought that this is, more than sulfasalazine hypersensitivity. So it was 35-year-old lady who had otherwise, looking like rheumatoid arthritis. And we thought that is probably more than rheumatoid arthritis. So we ordered ANA by immunofluorescence and which was positive. Complements were normal. So we ordered an ANA profile and it was reported as negative, as you can see in this report generated from AIMS, Autoimmune, basically the automated generated auto, basically this reporting, the automated reporting. And you see all the antibodies have been given as negative. But if you ask them to provide you the profile picture, you see this patient has got a pattern here. dsDNA is showing a band, nucleosome is showing a band, and histone is showing a band. This pattern is usually not seen unless until patient has got a lupus spectrum of disease. So even if this report was negative, we asked for a specific dsDNA by ELISA, and you see it came as sky high. So that is how you go on deciphering a case or chasing a case or chasing a report. But it should not happen when you don't have any suggestive symptoms. Otherwise, it's a never-ending race. So anti-dsDNA should always be tested by ELISA before you call it negative. So when we are ordering a test, we should order to make it a difference. I have got a 20-year-old girl who has got bilateral symmetrical inflammatory polyarthritis. There could be various reasons for it. Patient could have rheumatoid, patient could have JIA, patient could have lupus, Sjogren. How do I go about it? I look at other associated symptoms. If there are fever episodes, photosensitivity, I would think of lupus and order an ANA. No fever, duration is 3 months, likely RA. Deformities, scleroitis, duration of 10 years, I would rather think of rheumatoid arthritis or JIA and order again rheumatoid factor. Family history of psoriasis, duration is 3 months, past history of uveitis, goes into spondyloarthropathy spectrum. And if patient has got hypokalemic paralysis, osteomalacia, it is more likely to be Sjogren. I would order the test accordingly. I have got 55-year-old male, symptom of 2 months duration, high-grade fever, purpuric rashes over the legs, bilateral symmetrical inflammatory polyarthritis. So now the picture is changed. We were still so far discussing about young ladies. Now we have a male, old age, 2 months, explosive onset, rashes, high-grade fever, bilateral symmetrical arthritis. I have got these rashes. There is proteinuria with active sediment. What is my likely diagnosis? Here, even though the picture looks like lupus, everything could have occurred in lupus. What goes against the possibility of lupus is the age and the gender. These are not suggestive of lupus. I would rather think of ANCA should come positive, and I would like to make the diagnosis of GP or MP in this patient. Similarly, you see what I'm just changing. I'm just changing age and gender. 25-year-old female, similar picture. Everything is same. My first diagnosis here would be lupus. Accordingly, I would order an ANA. But what if ANA comes negative? Then I would start thinking of other diseases where such a picture could happen, which could be like vasculitis or Sjogren. Now, in this case, ANCA was positive, anti-MPO was sky high. So patient was diagnosed to have microscopic polyangiitis. So I would talk about these likelihood ratios, which means that it's basically a combination of sensitivity and specificity. And once you use it with your pretest probability, which is defined by certain set of manifestations, you can go on to get your post-test probability. So what do I mean? A patient who does not have any symptoms suggestive of vasculitis, you go on doing ANCA by ELISA, immunofluorescence, you are not going to get anything. Your post-test probability will be 0 because your high titers will be multiplied by this pre-test probability of 0.00003. But as you gather symptoms, more symptoms suggestive of vasculitis, sinusitis, pulmonary involvement, glomerulonephritis, combination of all this, your pre-test probability itself increases. Like you see here, out of 1, it is 0.85. So 85%, I'll be sure if a patient is having sinusitis, pulmonary involvement, and glomerular, this patient is likely to have vasculitis. So I'll show you with these examples. 30-year-old lady, completely asymptomatic. A panel is done. MPO comes 40. Now, if I try to use it using my knowledge of likelihood ratio and pretest probability, my pretest probability is 0.00003 because she does not have any suggestive symptoms. She's completely asymptomatic. And when I try to use it with MPO vasculitis level, MPO titers, my post-test probability comes to 1. I don't do anything. I just reassure and send the patient back. 65-year-old, old age, male, sinusitis, lung involvement, renal involvement. My pre-test probabilities itself is 0.85, 85%. Now, even if the patient has got high titers, which are 100 or 200, you see that my post-test probability goes to almost 100%. What if the titers are low? Even if my titers are low, my post-test probability is still 40. So that is the beauty of using your symptomatology with autoimmune diagnostics. Similarly, some other examples, and I'll just, I think, skip because otherwise it will be too late. So similarly, we can use it with the titers. 45-year-old lady, no diabetes, no hypertension, just 1 stroke. Somebody did an autoimmune profile. PR3 came out to be 20. Using my knowledge of pre-test probability, my post-test probability is only 10. So patient is unlikely to have vasculitis. Do these antibodies help in disease monitoring? So there is a patient who does these tests every month or every year, every 6 monthly, and you see the changing levels of rheumatoid factor. These changing levels with the swollen joint count actually doesn't match. And what I want to tell here is these tests are mostly one-time life events. Do not repeat them. Positive rheumatoid factor, ANA, ANCA, please don't repeat them. They don't mean anything. Repeating them, as Dr. Gupta also highlighted. There are certain tests like anti-DSDN and anti-MPO, anti-PR3 levels. They, to certain extent, tell me a possible flare of disease in future, but definitely not routine levels of rheumatoid factor ANA and ANCA. They have got different sensitivity and specificity across the diseases among the vasculitis group itself. And the role of pathologists in testing ANCA would be that nowadays the guidelines say that you should test both the methods simultaneously. These are done in parallel. Immunofluorescence and ELISA. Unlike ANA, where immunofluorescence is still the gold standard, here it has to be done in parallel. And if patient is having one of the gating strategy, but at least patient should have one of those gating strategy symptoms that I just showed you in the form of table. And discourage further testing if no such symptoms are there. But if a report has come to you with saying patient has got sinusitis, please test ANCA by IIF. But they have not asked for ELISA. I think the pathologist should report that testing by ELISA may be helpful in this case because that is one of the gating strategy symptoms. I'll come to APLA, 25-year-old pregnant lady who is G2A1, 8 weeks gestation. There is only arthralgia, no swelling, only pain. Nothing is there. ANA is speckled. Anti-Rho is positive. ACLA IgM is positive. So can we classify this patient to have APLA? So basically at this stage, nothing is required. Patient has got only one first trimester abortion. First trimester abortion, the commonest causes are hormonal, anatomical, some problem with the uterus itself, or maybe chromosomal causes. One abortion, we should not order all those battery of tests, which will ultimately prompt the gynecologist to start progesterone and parent. So these tests, I think we should reassure the patient, wait and watch, and then do not try to overclassify these patients to be having antiphospholipid antibody syndrome. Similarly, another first trimester abortion, similar lady, examination, no significant abnormality is there. Would I like to order any ANA or ANCA, anything? I actually don't require. First trimester abortion, as I told, the commonest causes are these. Antiphospholipid syndrome should be classified based on just one first trimester abortion. So these are just the classification criteria which says that if a fetus is aborted with maternal, so in basically, if there are more than three or more unexplained consecutive spontaneous abortion. This word is also important. Consecutive spontaneous abortions where maternal, anatomical, hormonal, or chromosomal causes have been excluded. Only then we try to classify these patients. And I think similarly, another case is there. So this is 35-year-old lady, known case of lupus. She's lupus for 3 years who has presented with DVT. Again, lupus, DVT, young lady, I would think of APS. I would try to do tests. One test has come positive. Is this report enough if given by the pathologist? What is the role of pathologists here? So if single report IgG is positive, we do not try to classify these patients, and we have to do risk profiling. So it is pathologist's duty to tell that you should try to test other you should try to do other tests which are required for doing this profiling. So then this patient has been tested for only LSE, ACLA, only IgG and IgM. So there are tests like anti-beta to GP1 which should be tested, which says that if patient has got double or triple positivity, any double, any triple, any LSE positivity for persistent high titers are called high risk APL profile patients. Their management is slightly different. So once you're getting requisition for only 1 or 2 or 3 tests, you should suggest that you please test for all the 5 antibodies, so that you don't just diagnose, you profile them, you risk profile them, because that will be beneficial for the patient. So now you see similar lady has got all 5 tests which are negative. Now, is this report enough? So this report is not enough. Lupus itself can cause DVT, but then there are other tests which are available commercially, like Dr. Ajay Gupta also highlighted. So we should go for other tests like IgA subtypes of anticardiolipin and anti-beta to GP1. So my take-home message is, as I told, autoantibodies are not equivalent to autoimmunity. Low-grade autoantibody positivity can happen in healthy viral infection, healthy individual viral infection, or even in old age people. When your autoantibodies are present with clinical features, they mean autoimmunity. Highly sensitive tests, when negative, rule out the disease. ANA negative lupus is virtually rare, at least for last 10, 13 years since I have started learning rheumatology and I have been in practice. I have not seen any ANA negative lupus. So don't try to start ordering tests. Rather do ANA in more dilutions. Positive predictive value of autoantibody tests is very low, so please order them very judiciously. Asymptomatic autoantibody positivity does not require any treatment. No treatment is required to correct the levels of autoantibodies, and never change therapy for correction of these levels. There is no 100% correlation of serology and phenotype. Clinical impression, clinical examination, your history, that gives you the best impression. And for pathologists, it is, as we have been taught, it is the grammar of medicine. So this has to be learned and discussed every day. I think there has to be one-to-one communication between the pathologist and the clinician who is doing the test, who are doing the test, so that once you get a patient who is ANA negative, but chances of lupus are very high, you can say that you please dilute it further. ANA, we request pathologists to report in terms of dilution pattern and intensity. Anti-dsDNA should be tested by ELISA. You should not exclude just by means of ENA profile. And it is always better to have an ENA profile bands, pictures also with them. APS profile, at least 5 commonest autoantibodies have to be tested, IgA subtypes if all are negative. And ANCA gating strategy always helps in basically better ordering of these tests. Thank you, and I will be happy to take the questions.
Thank you so much, Dr. Ranjan Gupta, for the wonderful presentation, such insightful presentation you have given. And I'm sure all the audience are going to recommend their patients to you only, the way you have explained things. As one of the attendees have written that good evening, sir, can I talk to you once regarding my condition? So I said there are no other questions, but your presentation was amazing. So thank you so much, Dr. Gupta.
Thank you, ma'am.